Whenever we do the hip joint, it has multiple components. You can divide it between a medial, anterior, a lateral, and a posterior evaluation. Given the amount of time we have today, we will concentrate on just trying to get the anterior and the lateral aspect of the hip, and the demonstration will be limited to those. Usually we start with the anterior side. The patient lies with the legs slightly externally rotated, and she's supine, so that makes it easier for us to align our transducer along the planes we would like to evaluate in the anterior part of the hip. For the anterior part of the hip, it is usually good to start with a curved transducer. There are multiple variable range of frequencies. The one I'm using today is a 1.5, but some of the new transducers are 2.9, and those are able to give you much better resolution. And the reason we do this is because of the depth. As you know, in ultrasound, the deeper you have to go, the lower is the frequency. So for a hip joint, we prefer to have a curved transducer. Now you have to imagine that the femur kind of goes in this orientation, and then the neck of the femur is a little bit more oblique. So we are not going to follow the anatomical planes when we do the ultrasound exam, but we will define the planes based on the orientation of the femur itself. So the neck of the femur goes at a slightly oblique angle to the shaft of the femur, and our first view is always going to be aligned along the lie of the neck of the femur, so that we have the acetabulum, the femoral head, and the femoral neck in one view, and we have a good look at the capsule of the joint. So by convention in ultrasound, when you are doing a long image, you know that the left side of the image is the cephalic part, and the right side of the image is the caudal part. And we're trying to orient the same thing here. So in this orientation, I'm going to use a little arrow here to demonstrate the structures. You have this echogenic structure that is the acetabulum, then you have the femoral head, and then you have the femoral neck here. A slight orientation, a slight angulation of the transducer helps us to look at the capsule. This is the capsule of the joint. Now remember, the capsule of the joint comes down into the neck of the femur shaft and then reflects back at the neck. So at this point, you have almost 2 layers of the capsule because of the reflection. However, this also makes it very easy to target for any intra-articular injections. If you can get the injection in this spot, you pretty much have got the injection in the area of the hip joint. Now, sometimes if you are able to get a good angulation, you might be able to see the labrum anteriorly. In this instance, it's just a little bit more difficult to find that hyperechoic wedge of the labrum. Now, the capsule is really well seen, and you can see I'm pressing hard here to show us a very nice uniform capsule as it comes down to the neck and then makes a reflection. If I was to freeze this image and measure the AP of this capsule, then it is approximately 3 to 4 millimeters. A capsule less than 7 millimeters is within a normal variation. And this is also the place you would look for any joint effusions. So after you've finished looking at the capsule, you look at the tendon which is anterior to the joint, and that is the psoas or the iliopsoas tendon. This is the transverse view of the psoas tendon. So you can see here the tendon is really hyperechoic, right anterior to the acetabular ridge. And you can see that now when I compress here, that's the vein. So we have the femoral vein, the femoral artery, and then the iliopsoas tendon right here, anterior to the acetabulum. Right behind this is the bursal space. That's usually a great place if you have to do a iliopsoas bursal injection. Generally, you can come from the lateral side, get through the muscle, and right under the tendon so that you can inject fluid in the tendon sheath and in the bursa. And both of them can be pretty accurately done in a transverse way. Now, when you go long on the psoas tendon, as it goes deeper for its insertion, you get a lot of anisotropy because of the angle at which it's going. So sometimes you have to turn your transducer, as I'm doing here. You can see how my transducers lower part gets angulated so that I can hit the tendon at 90 degrees. So when I do that, now you can see how the echogenic psoas tendon is seen inserting onto the lesser trochanter over there. So that's a beautiful view of the psoas tendon distally. Now, in the hip joint anteriorly, there are two more tendon insertions we should look at. One of them is the rectus femoris, and the other one is the sartorius. Many times they can be cause of innocuous hip pain. So once you've evaluated the joint space for any effusion, you looked at the psoas tendon for any tears, you looked for fluid in the iliopsoas bursa, you should also go and look at the insertions of the proximal insertion of the rectus femoris tendon. Now the rectus femoris tendon starts from the anterior inferior iliac spine. So you can see here that's the anterior inferior iliac spine, and the tendon originates from there and goes down. You can see there's a lot of anisotropy just deep to the tendon. Why? Because it has two heads. This is the second head origin, the reflected head of the rectus femoris. So you can see it's not really well seen, and you might have to finagle your transducers or choose a different one to find the reflected head, but essentially that anisotropic tendon coming up is the reflected head of the rectus femoris. No tears, good insertion onto the anterior inferior iliac spine. And the same side, if you go higher up, you want to find the anterior superior iliac spine, and that is where the sartorius origin takes place. It is extremely superficial. So we might have to change the transducer for this. Now, before we wrap up this anterior evaluation of the hip, I want to go back to the iliopsoas tendon to demonstrate one thing. Very often we get the request to look for iliopsoas tendon impingement, or rather what they call as the snapping of the iliopsoas tendon. What is the intention when we are evaluating the iliopsoas tendon? So here is the hyperechoic iliopsoas tendon. That is the iliacus muscle, so the iliopsoas muscle tendon unit. When patients generally externally rotate and abduct their limbs, what happens is a part of this muscle goes under the tendon. And when the tendon flops back in view, that's what causes the snap. To elicit the iliopsoas snapping, what sometimes we do is we will flex the knee joint, externally rotate the limb, and then straighten it. At this point, the interposition of the iliopsoas tendon and the iliacus muscle makes the sound which patients will come and say, I feel a snap in my hip. So while we do that, it is important that the transducer is in transverse orientation on the psoas tendon. It can be very difficult to do that. It takes some practice, and you might have to do it many times before you can make a good judgment of whether there is a snap or no snap. As you can see on the screen, this hyperechoic structure, that's the stabulum. This hyperechoic structure is the iliopsoas tendon. So now slowly we'll ask our model to bring the leg up. We stay on that tendon. You can see the tendon is still there. The muscle is trying to go around it. Externally rotate. You can see the muscles going up. Tendon stays there. And we straightened again, and the tendon has stayed exactly there. If this was an abnormal case, this muscle would have come under the tendon, insinuating itself between the tendon and the stabulum. And then in the final position of the limb, it will pop back out, and that's what causes the snap. So what we've done now is we've gone to the ML615 linear transducer. We're going to try and use this, look at the insertion of the proximal insertion of the sartorius muscle at the anterior superior iliac spine. So in a longitudinal way, you can always palpate where the anterior superior iliac spine is, and then keep the transducer right there. Now you can see on the equipment that is the bone, the anterior superior iliac spine right there, And right there, that is the antithesis of the sartorius tendon muscle unit. If there is any hypoechogenicity in this area, that can sometimes be a cause for chronic pain, and then you have the sartorius muscle as you go distally. Since we already have the linear transducer, we will slide down to find the anterior inferior iliac spine and see how we can see the rectus femoris origin, and see that beautiful rectus femoris origin right there. I don't see any irregularity on the underlying cortex. Great origin. And as I told you, there is this anisotropy you can see. Those are basically the fibers which are coming from underneath, which is the reflected head of the rectus femoris. And sometimes if you angle enough, that's the direct head, and if you angle enough, you can find the reflected head as it comes up and joins this myotendinous junction. So that's the origin of the rectus femoris. So for the lateral hip evaluation, it's predominantly an evaluation for trochanteric pain syndrome. Patient usually has a mild angulation of the hip that allows us to establish where the trochanteric ridge is. And the first view is a transverse view in which you can see the ridge. So you have, in this instance, you have the anterior part, and then that triangle, and then the posterior part. Now this is really important because that triangle is essentially dividing and defining the facets of the trochanter. So you have the anterior facet, which is anterior to that triangular sort of prominence. Then you have the lateral facet, which is posterior to it, and then you have a posterior facet. So we have an anterior, lateral, and a posterior facet. And if you look at the anatomy of the gluteal tendons, there is also one small posterior superior facet from where a part of the gluteus medius tendon takes off. So what are the two main tendons we're looking at? We're looking at the gluteus minimus and the gluteus medius. And when you do a transverse view and start out, this ridge allows you to differentiate between the two of them immediately. So you can see anteriorly, you will find some aspect of the gluteus minimus tendon, and then on the lateral facet, posterior to this prominence on the trochanter, you will find parts of the gluteus medius tendon. The gluteus medius tendon has anterior and posterior components, and it gets a little bit tricky to try and differentiate them on the ultrasound exam. Now, because of this unique orientation of the trochanter, the transducer doesn't follow any anatomic plane, but tries to get the best cross-sectional and long views it can based on the expected trajectory of the tendon and the muscle. So in this position, we know that we found the trochanteric ridge, and as in that position, now I angle anteriorly. You can see I angle anteriorly, and when I angle anteriorly, there is this gluteus minimus tendon, which is better seen. You can see it's hyperechoic. And I can very easily make it hypoechoic, which is the anisotropy. So I have to make sure I angulate properly, okay? So we find the ridge there, go anteriorly, and then make an angle so that the insertion of the gluteus minimus tendon is hyperechoic. This tendon moves anteriorly towards the iliac crest. So I can keep this in view in the center of the screen and move anteriorly, but in my mind, I'm going anterior towards the insertion. And you can see what happens. The moment you start going up, the tendon becomes very dark because of anisotropy. So multiple angulations are required to keep that tendon white, or at least in an appropriate cross-sectional view. Now, if this is a fairly broad gluteus minimus tendon here. Now, as I proceed proximally, see how the tendon becomes a little bit more prominent anteriorly, and as I go further out, the tendon starts spreading out and disappears. Why? Because it forms the anterior aponeurosis of the gluteus minimus tendon. Now this is really useful though. Once you've got this nice transverse view and you know this is where the tendon exists, to get a nice long section, all we need to do is to go 90 degrees to that axis. And the proximal part of the transducer is somewhat anterior because it's trying to follow the gluteus minimus trajectory. When I'm in that position, you can see here how well the gluteus minimus tendon is seen. Very hyperechoic, beautifully inserting, and as I go proximally up, you can see this is the gluteus minimus tendon. Superficial to the gluteus minimus are fibers from the anterior gluteus medius muscle. So don't get fooled by these. Think about the gluteus minimus tendon becoming an anterior aponeurosis and the bulk of the muscle is posterior to it. If I increase the depth of the transducer, you can see I can follow the gluteus minimus to its insertion onto the iliac bone. Here you can see we've laid out the entire gluteus minimus muscle and comes and becomes the tendon. So now what do we do with the gluteus medius? So we go back to our increase the depth, we go back to our triangle view of the trochanter. This time, instead of going anteriorly, we swing posteriorly. When we swing posteriorly, we will have what is called the bare area of the lateral facet. So we don't want to find the tendon there. Tendon's slightly more posterior than you expect. So you find your ridge, go posteriorly, and now again, this is the tendon here. You want to make it nice and white, you can see it there. And this tendon has two components. One component is going anteriorly, and the second component, far posterior, is much more bigger, and that is going to go posteriorly. So when I make a long view at the lateral trochanter, very important to go back to your transverse views, make sure you don't get confused and start imaging the gluteus minimus again. Now we are back in gluteus medius zone and turn our transducer 90 degrees, and we can see a very, very thin tendon over there which is coming to insert onto the lateral facet of the trochanter. And as you follow it back, you can follow it back into the muscle. If you go a little bit further back and angle anteriorly, you will find a much larger tendon that takes off from the posterior superior facet, and that is the tendon that leads to the posterior fibers of the gluteus medius tendon. Many times this one is missed because it's a little bit more posterior and superior than expected, but it's fairly robust and it can be seen really well. So now, once we've looked at the intact gluteus minimus and medius tendons, we go back to the midline and we try to find our triangle again. Because what's our intention? Now our intention is to look at what's happening to the iliotibial band. The way to differentiate where the iliotibial band lies is by making simple movements of the legs. So here, I'm holding her from the ankle, I'm going to abduct. And see, the moment I do that, what's happening? That iliotibial band is sliding over the gluteal tendons. And this is critical because what it allows us to know is that this is the iliotibial band, and between it and the gluteal tendons is your bursal space. Many times, that's the space where you will find thickening or you'll find fluid and might be your target for your injections. You can get the iliotibial band in view and go proximally up as it interdigitates with the muscle fibers, and you can go all the way to its insertion onto the iliac crest. We're going to go to the iliac crest and find the insertion of the iliotibial band. And as you can see, we have slight irregularity of the enthesis there, some small calcification, so some chronic tendinosis of the ITB is obvious at the proximal insertion. This is a fairly important structure to visualize. I've seen a lot of pain patients have related to the ITB band and friction over the underlying structures. Even in our model, the ITB band appears to be somewhat thicker compared to what you would normally expect. And then you can trace this down as it goes along the lateral side of the leg. So here we have a really good view of the gluteus medius tendon. As you can see, it's fairly thin by the time it comes to insert onto the lateral facet. And then if I slide my transducer a little bit down, you start seeing a much more thicker insertion, and that's the posterior tendon of the gluteus medius, much more robust and much more easily seen than the tendon formed from the anterior fibers. So in a nutshell, we've looked at the lateral side of the hip, looked at the gluteus medius, the gluteus minimus tendons, the iliotibial band, and the trochanteric bursa. It's a fairly unique joint, but one of the key take-home points is that the complex orientation of the myotendinous unit needs to be understood to get really good images and to understand where the pathology lies in the lateral hip. So with that, we have come to an end of examination of the hip from an anterior and a lateral aspect. Majority of patients who come with hip pain will usually require a hip anterior or a lateral evaluation. Patients who have very focused pains in hamstrings,